Hello everyone, welcome to this special INICET May 2024 recall sessions brought to you by Manipal MedAce. I am your pharmacology educator Dr. Arpit Agarwal. I hope the audio and video is clear. Hello everyone, welcome. So we will start with our discussion. I can see some participants have already joined. So welcome again all of you. Welcome Keshav, Aniket, Tega, Ranjana, Dr. Naren. Welcome all of you. So we are going to discuss the pharmacology MCQs asked in INICET recently conducted. As you will see, all the questions have been asked from our Manipal MedAce lectures. I will show you not just the questions but their explanation already mentioned in our notes, and you will believe that if you study from Manipal MedAce, you will be able to solve all the questions which are asked in INICET and obviously in NEET and FMG exam as well. So without any further delay, I will begin with the first questions. Okay, let me know if the audio and video is clear. So the first question, before we go to the questions, here is a disclaimer that all the questions that we are going to discuss are based on recall, and the final questions will be available in the Manipal MedAce app soon after any corrections if needed. So let us begin with the first question. So the first question on your screen. A child with enterococcal endocarditis is allergic to penicillin. Which drug should be prescribed? So we have enterococcal endocarditis, but the child is allergic to penicillin. What will be the best drug out of the given? The options include vancomycin, aztreonam, piperacillin, or ceftriaxone. Now this is a question from a very important topic. It has been asked previously as well, and we have discussed this in our lectures in detail. Now we all know that for enterococcal endocarditis, ampicillin is the drug of choice. But since there is history of allergy to penicillin, then what are the other options that we could choose? Vancomycin, aztreonam, piperacillin, and ceftriaxone. So I'll show you what we have already discussed in our lectures and also in our notes. So you see this, the same question. Actually, this question has been asked directly from our notes, and this is the question that I have discussed in our Manipal lectures and also available in our notes. So we have a question which says infective enterococcal endocarditis and medical history is severe anaphylactic reaction to penicillin G. So same question, the best treatment. Now see here, the answer is also given in our notes. As you can see, such a simple question. Ampicillin with or without gentamicin is the drug of choice if the patient is not allergic for enterococcal infection, and if there is history of allergy, then we cannot use ampicillin because it is a penicillin group of drugs, correct? So the correct answer will be vancomycin, and that is already given in our notes, as you can see. So that will be answer to the question that was asked, that is vancomycin. Vancomycin will be the answer to this particular question. Please, all of you, also let me know if the question is correctly framed and also keep providing your answers. Okay, Keshav, Aniket, Ranjana, everyone. Now, the question that arises, which confuses most of the students, is that if there is history of allergy to penicillin, then aztreonam is a beta-lactam antibiotic with the least cross allergy to penicillin. So why aztreonam is not the answer here? And that is what is the concept we need to understand. For that, we need to have a bit of knowledge of microbiology. So enterococcal is a gram positive bacteria. Enterococcus is a gram positive. And Astronom acts only on gram negative bacteria. Astronom is an effective antibiotic only for gram negative. So when is Astronom used as an alternative to penicillin, that you need to understand, and that also has been explained in my lecture. So you see the same or the similar appearing question which I have explained in our lectures, Manipal MedAce lectures. Here you see a similar appearing question which says that 40-year-old male admitted due to gram negative sepsis. Again, medical history includes severe anaphylactic reaction to penicillin G. Now, what is the most appropriate treatment? So, what you need to understand, in patients who have allergic reactions to penicillin, if there is a gram negative infection, only then Astronom can be chosen as an alternative to penicillin. If you have a gram positive infection like the one enterococcus, then Astronom will not be effective, and then we need to choose vancomycin. Okay, so I hope it is clear why the question number 1 with enterococcal endocarditis, why vancomycin is the correct answer and not Astronom. Not Astronom. This is because I'll repeat, enterococcus is a gram positive infection and Astronom can act only on gram negative, right? That is why here Astronom will not be the correct option. It will be vancomycin, which is the effective alternative to ampicillin if there is allergy to penicillin. So I hope that is clear. Give me a thumbs up if this question and the underlying concept is clear to all of you. Okay, so give me a thumbs up in the chat so I know that you have understood what is the small but very important underlying concept that you need to understand to differentiate various questions that are presented to you with allergy to penicillin history. So let me know all of you if you have understood this particular simple but very important question, very frequently asked. For gram positive, go for vancomycin, and if there is a gram negative infection, then you go for Astronom in patients who are allergic to penicillin. Okay, so I hope it is clear to everyone. Keshav, Aniket, Ranjana, I hope it is clear. Okay, so now we move on to the second question. Second question, again, simple, direct question discussed in our notes as well, and I'll show you which leprosy drug causes skin pigmentation. So, leprosy drug causing skin pigmentation. Rifampicin can be used in leprosy, so is Dapsone, so is clofazimine. Olanzapine is obviously an antipsychotic drug having no role in leprosy. We can rule that out. Now, this question is based on memory. It's a memory based question, and we need to remember it is clofazimine. Which actually is a dye. It is a coloring agent which finds use in leprosy as well as in multi-drug resistant tuberculosis, and this drug is notorious for causing a brown or coppery red pigmentation of skin. So a brownish skin pigmentation can be caused by clofazimine. Clofazimine is the drug. Again, the question was well discussed in our lectures, and you will see this is a screenshot from our notes, and you see clofazimine. We have written that it has two mechanisms of actions. It interferes with DNA function and it has anti-inflammatory action. Based on the DNA interfering action, it finds used in leprosy as well as in multi-drug resistant tuberculosis, and based on anti-inflammatory action, it finds a use in lepra reaction. So the mechanism, uses clearly explained. Side effect, the first side effect that we have mentioned is skin pigmentation. You can see the coppery red or the brownish skin pigmentation that appears with clofazimine. So these are the only questions which are asked from clofazimine, and again If you have revised from my notes, you will find question is very simple and clearly discussed. Okay. So again, that's the second question, memory based question discussed in our notes, clearly written, no confusion here. Okay. So that is the second question. Moving to the third question, very, very important and sometimes confusing. Although this is a repeat question from AIMS. 5 years ago, similar question was asked in AIMS about the anticoagulant and their monitoring. Anticoagulant and their monitoring. Again, those of you who have studied from my notes will find it extremely simple. Why? This is why, because. So this is again a screenshot from my notes in Manipal MedAce, and you will find that clearly we have divided anticoagulants into two types. One are parenteral, those which are given via injection, subcutaneous or IV, and the other ones are oral. So clearly we have written among the oral, if we see, then we find warfarin is the first, which is a coumarin derivative and interferes with vitamin K dependent activation of clotting factors. You will find written in green PTINR. This means that this requires monitoring. So warfarin is one oral anticoagulant that requires monitoring. Another oral anticoagulants are the newer direct acting. So we have direct thrombin inhibitor dabigatran and direct 10 inhibitors, which are xabans, rivaroxaban, apixaban, edoxaban, all the names, whether it is rivaroxaban or apixaban or edoxaban, all of them end with XA, and XA means direct 10A inhibitor. As you can see, no monitoring is mentioned in front of their names, so they do not require monitoring. Okay, so you can also remember dabigatran has bi. Bi means 2, and that is why it is a thrombin inhibitor. Thrombin, remember, is factor 2. So that is another way of remembering dabigatran, but no monitoring is required, clearly mentioned in the notes. Coming to parenteral injectable anticoagulants, there are two types, heparin-like. Heparin-like, we have UFH, which stands for unfractionated heparin. It inhibits factor 2A and factor 10A, and again you see APTT written in front of it. APTT written in front of it, that means which requires monitoring, unfractionated heparin, via which test, APTT. Low molecular weight heparin and fondaparinux, they do not require any monitoring. They inhibit mainly factor 10A. Then another is direct thrombin inhibitors, which are injectable under the parenteral, and you see APTT written in front of them. APTT is written in front of them. The names end with rudin, bivalirudin, lepirudin, and ergatroban. So all these require monitoring via APTT. Ergatroban requires monitoring both via APTT and also via PT. So that is generally not asked, but as a principle, you can remember the injectable or the parenteral direct thrombin inhibitor, lepirudin, bivalirudin, ergatroban require monitoring via APTT. So clearly mentioned in our notes, APTT monitoring required by unfractionated heparin, direct parenteral thrombin inhibitor, and prothrombin time or INR monitoring required by warfarin. Other anticoagulants generally do not require monitoring. Coming back to the question, now we can understand. Fondaparinux, no monitoring is required. Dabigatran, no monitoring is required. Lepirudin, direct parenteral thrombin inhibitor, requires monitoring by APTT, as I have explained. Enoxaparin is a low molecular weight heparin. Normally, it does not require monitoring, but in three conditions. If the patient is a child or patient with chronic kidney disease, if the patient is obese, or if the patient is pregnancy. So in CKD, obese or pregnancy, something you can remember by simple mnemonic of COP. Under these three conditions, the low molecular weight heparin like enoxaparin may require monitoring. So normally low molecular weight do not require monitoring, but under CKD, under obesity, or if the patient is pregnant, they require monitoring, and we do it by anti-factor 10S. So that is a special point which has not been asked so far. But since this question on monitoring of anticoagulant has been asked, maybe in upcoming INICET this question can be asked. Okay. So I hope it is clear, and you can see that this has come directly again from the notes as I have clearly shown to you. So I hope all these three questions that we have discussed so far are clear, and you can see the advantage of studying with Manipal MedAce. Everything in this paper has come directly from the notes. No question has come from outside, clearly written with proof I am showing you. So if you are liking the session, do not forget to show your love by clicking that thumbs up button. Okay, that's the only reward that we want, your love, your appreciation, which keeps us motivated. Okay, so do not hesitate, continue to press that like button. Next question, which of the following is a PCSK9 inhibitor? PCSK9 inhibitor. Wonder Gappe, thank you for your appreciation, thank you, and welcome Rahul as well. PCSK9 inhibitor. Now this particular question or this particular topic is extremely important. It is discussed in detail in our lectures, in our rapid revision, and also if you attended our INICET rapid recall or most important question that we had on YouTube in month of April, this point was discussed in that YouTube session as well. So PCSK9 inhibitor, again I'll show you that it has been clearly discussed in our lectures. Let us see. So this is a simple slide in our notes, directly taken from our notes, where you can see the mechanism of all important lipid lowering drugs. You can see here that statins mechanism is shown. Statin mechanism is shown. They inhibit HMG coenzyme reductase, number one. You can see another drug, inclisiran, very important, and this is going to be an expected question in either NEET or upcoming INICET. Mark my words, this drug will be asked. Inclisiran is also affecting PCSK9 pathway. As you can see, it is a small interfering RNA. Small interfering RNA which interferes with the RNA of PCSK9 protein. Okay, so it interferes with the messenger RNA, mRNA of PCSK9, and again inhibits the synthesis of PCSK9 protein by the liver. So that is again a drug interfering with PCSK9. Then once PCSK9 has been produced by the liver, it can damage the LDL receptor. So we have QMAB drugs, two drugs, alirocumab and evolocumab, clearly written, you can see. And these drugs are as saying PCSK9 inhibitor. PCSK9 inhibitor, clearly shown. They bind to this PCSK9 protein, degrade this protein and prevent the damage to LDL receptor. Alirocumab, evolocumab, clearly shown. And there is your INICET question which was asked. So this is clear. Further, you can see in the same diagram ezetimibe. Ezetimibe is another important hypolipidemic drug which is asked very clearly. Its site of action clearly shown, GIT, and which protein it inhibits? It inhibits the transporter NPC1L1. Again shown. This is a single diagram given in our notes, discussed in my lectures on Manipal MedAce, and all questions related to mechanism of hypolipidemic drugs asked so far have been asked from this diagram. Okay, so that is what we have discussed. That is what you need to understand, how to study, from which app to study, and which app is giving you direct questions. So now you come back. We all understand now evolocumab. Another thing, if you forget, you can understand LOC, alirocumab, evolocumab. LOC stands for, you can remember it by lower cholesterol. So these are drugs, evolocumab, which are PCSK9 inhibitor, and they lower what? They lower your LDL cholesterol. This is how you can remember. Look at the other options. MTP. Lomitapide is a drug which has MTP in its spelling. It inhibits the mitochondrial triglyceride transfer protein. Simple to remember. Bempedoic acid is a new drug. New drug, and this may be asked in upcoming examination. Bempedoic acid will inhibit the ATP ATP citrate ATP citrate lyase. This is another enzyme involved in cholesterol synthesis, and bempedoic acid is a new oral drug. Please understand, this is the latest oral drug to decrease cholesterol synthesis like statins. So this bempedoic acid is going to be another high value target for upcoming INICET and NEET. Remember, it inhibits ATP citrate lyase enzyme in liver, decreases cholesterol synthesis given orally like statins. Torcetrapib has CETP in its spelling and inhibits an enzyme cholesterol ester transfer protein. CETP inhibitor. This drug was banned. This drug is no longer available due to increased mortality. Patients who received this drug actually had a greater mortality, so this drug is no longer available. Okay, CETP inhibitor. So I hope this question is clear, and you can see all the important points were discussed in my lectures. Okay, so I hope this point is clear. PCSK9 inhibitor, alirocumab, evolocumab have been asked. Inclisiran is a potential target for upcoming examination. So moving ahead, please continue to also share this session live with your friends in your college or your study group so that they can also join and they can also understand what benefit or what is the unique advantage of studying with Manipal MedAce app. All the questions you will find from pharmacology, and I'm sure with other subjects also, have come directly from our lectures, from our notes. Fifth question, which is a side effect of teriparatide? So the drug has para in its name. That reminds us that drug is a PTH, parathyroid hormone analog. So first, the drug is a PTH analog consisting of 1 to 34 amino acids of parathyroid used for treatment of osteoporosis. That is the background about teriparatide. The name is ending in tide. Any drug ending in tide is a peptide, cannot be given orally, that we know. So the drug is given by daily subcutaneous injection. That is the background about teriparatide. Now, which of the following is a side effect of teriparatide? Now, how do we understand and remember? So again, I'll show you our notes, clear written. See everything. I mean, it is surprising that everything that we have written and the only point that we have written has been asked in INICET. So you can see drugs that increase bone formation. Increasing bone formation. Clearly written. What are the drugs? Teriparatide, abaloparatide. Two drugs written. One is recombinant PTH, which I have told you, and abaloparatide is recombinant, R for recombinant, parathyroid hormone related peptide. Both are given by subcutaneous, both are ending in tide. That means both are peptide, cannot be given orally. Now these drugs are increasing bone formation. They act intermittently, and intermittent PTH action leads to bone formation. That we know as mechanism. Now, as you can see, their side effects are also written. They cause hypercalcemia, and they are contraindicated in which patients? Patients with osteosarcoma or Paget's disease. Why? That is all you need to understand. See, in osteosarcoma or Paget's disease, patients who have these history, they are likely to have increased bone formation when you give these drugs, which can worsen osteosarcoma or Paget's disease. So any patients where there is chance of having more bone formation like osteosarcoma or Paget's disease, or patients who have open epiphysis, any patients who are likely to have excessive bone formation, we avoid these drugs. We avoid teriparatide in osteosarcoma, in Paget's disease, and in patients with open epiphysis. Why? Because this drug is causing bone formation, and in these patients, increased bone formation can lead to worsening of osteosarcoma or causing of osteosarcoma. So you will avoid these drugs in these conditions. The third drug, which is also related to increase in bone formation, is an antibody called romosozumab. Only these points are mentioned in my notes, and from these points you can see all questions which have been asked related to bone formation can be answered. So what is the side effect of teriparatide? I hope now it is clear. Osteosarcoma. Osteosarcoma. Any patients with history of osteosarcoma, teriparatide is absolutely contraindicated. Osteonecrosis of jaw is a rare but potential side effects of, I hope you remember, bisphosphonates, particularly zolendronate. A very highly potent bisphosphonate is at risk of causing osteonecrosis of jaw. Okay, so this question also, question number 5, directly from our notes. Okay, everything clear? Any problem so far? To anyone? Please, if there is any confusion or you think the question was not asked in this format, please mention in the chat box so that we can make adequate or necessary corrections. Okay, do not hesitate. These questions, as I said in the beginning, are based on recall. I have taken maximum precaution to frame the exact question, but if you think you appeared in the exam and if you think the question was different, do let me know. Okay, so now moving to the next question. Identify the anti-diabetic drug useful in patients with CHF with low ejection fraction. So the question is asking about an anti-diabetic drug. So first of all, we have to see if in the options there is any drug which is not used for diabetes. We can rule that out. So dapagliflozin, metformin, liraglutide and glimepiride, all are diabetic drug, so that does not help us. Now we have to know which drug, being anti-diabetic but also useful in congestive heart failure with low ejection fraction. Again, a very important topic, has been asked recently in INICET and has been studied in detail in our rapid revision videos. I'll show you what I taught you in our rapid revision. So benefits of SGLT2 inhibitors. So sodium glucose transporter type 2 inhibitors like gliflozin, dapagliflozin, empagliflozin, canagliflozin, they have some benefits. What are those benefits? They reduce hospitalization for congestive heart failure. The very first point that was taught under this class of drugs is they reduce hospitalizations for congestive heart failure and cardiovascular mortality. And there we have our answer, that the anti-diabetic drug useful in patients with CHF is SGLT2 inhibitor. This is the first point I have taught in our rapid revision under SGLT2 inhibitor, and that is your INICET question. Further, if we continue, what extra questions can be asked? These drugs also reduce the progression of renal disease. So they are also good for patients with diabetes with CRF. Here you may also want to know that ACE inhibitors, ACE inhibitors or angiotensin receptor blocker, they are also benefit in diabetic nephropathy. So are SGLT2 inhibitor. And the third drug, which is similar to spironolactone, mineralocorticoid or aldosterone antagonist, is finerenone. So these are three drugs, ACE inhibitor ARBs, SGLT2 inhibitors and finerenone, which are also beneficial for diabetic patients with nephropathy or chronic kidney disease. Again, SGLT2 inhibitor, this point may be asked in subsequent examination. Then the importance of this particular point is so much, SGLT2 inhibitors, that we have also discussed this in our CHF chapter. So if you have not studied endocrinology from my app, at least you might have studied very important chapter of CHF. And again, you find that agents which reduce mortality in CHF is beta blockers and a combination of hydralazine with nitrates, Midol. Arni, which is a combination of sacubitril with valsartan, ACE inhibitor ARBs, inhibitors of SGLT2, that is gliflozins, and the mineralocorticoid antagonist, that is spironolactone. So these are the drugs which decrease mortality in CHF. Remember by the mnemonic, best agent, B for beta blocker, Midol, A for Arni, ACE inhibitor ARBs, I for inhibitors of SGLT2, and M for mineralocorticoid antagonists. These are the drugs which reduce mortality in CHF. So whether you have studied endocrinology or you have studied congestive heart failure, the point was well covered in our rapid revision that which antidiabetic drug are beneficial for CHF patient, that is SGLT2 inhibitor, dapagliflozin, canagliflozin, empagliflozin. Okay, so this is also covered again from our notes. Simple question number 7. This question I hope everybody has answered correctly. This question has been repeated many times. Identify the antidiabetic drug increasing the risk of urinary tract infection. I hope everybody has answered. Dapagliflozin or the SGLT2 inhibitors. These drugs increase glucose loss in urine and therefore the risk of urinary tract infection, vaginal candidiasis, Fournier's gangrene, these kind of urogenital infections, they go up. The point was well discussed in notes, in main lectures, in rapid revision, and this is the table. This is the table that I have shown in main lecture as well as in our rapid revision, that which antidiabetic drug and where to avoid. These are the high yield tables that we have included in our rapid revision sessions, which help you solve not one question but at least 7 to 8 questions. So metformin should be avoided in patients with severe renal disease. If the GFR is less than 30 ml per minute, you will avoid metformin. In chronic alcoholics, you will avoid because it increases the risk of lactic acidosis in these patients. Glitazones like rosiglitazone, you will avoid in patients of myocardial infarction and edema like CHF. Dapagliflozin, the question that has been asked, should be avoided in patients with history of UTI and with the diabetic ketoacidosis because they mask the high glucose of diabetic ketoacidosis. The GLP agonists like exenatide, liraglutide should be avoided in patients with pancreatitis or with history of gastroparesis, and sulfonylurea should be avoided in severe renal disease and obesity because they increase weight of the patient. So all questions which are generally asked from diabetic drug and their side effect or contraindication have been discussed in detail, and you can solve all the questions. This table alone, if you remember, you will find that all previously asked question about diabetic drug and their main contraindications or way to avoid can be attempted just by looking at this particular table. So I hope the question of UTI and diabetic drug you will never ever forget. Okay. Another drug, anti-diabetic drug causing diarrhea as a side effect. Now diarrhea as such can be caused by majority of oral drugs. But when we talk about anti-diabetic drug, then metformin, the most common problem with metformin are the GI side effects such as nausea, vomiting, or unexplained diarrhea. Again, this point has been well discussed in our lectures. Well, this is the most common, not the most serious, but most common problem with metformin are the GIT side effect, nausea, vomiting, or diarrhea. Remember, liraglutide can also cause the GIT side effect, but they are usually nausea and vomiting only. The GLP-1 agonist, exenatide, liraglutide, they generally do not cause diarrhea, they generally cause nausea and vomiting only. That is why this will not be the answer. Sulfonylureas are mainly problematic for causing weight gain or hypoglycemia. Diarrhea or GI problems are usually not seen with sulfonylurea such as glimepiride. Sitagliptin, these drugs are generally safe with not much of problem. They generally can cause the nasopharyngitis or upper respiratory tract infection. Are sometimes seen with sitagliptin. Okay, so metformin will be the best answer here. Although I must say that asking diarrhea side effect question is a bit unfair on the examiner because diarrhea can be caused by most oral drugs. So you cannot say that this oral drug will not cause diarrhea, but out of the given option, metformin is the best answer here. Okay. So please continue to provide your feedback. If you think the question is not correctly framed, or if you have any problem with the explanation. Correct dose of steroids given in pregnancy. So in cases of preterm delivery, for maturation of the fetal lung, we give steroids. Now dexamethasone, betamethasone. How to remember? How to remember? Clearly explained in my notes. This is, you can see from our Manipal MedAce, from the chapter of corticosteroids, page number 3, use number 6, clearly mentioned, for fetal lung maturation. You give steroids. Why you give steroids? Because they increase surfactant production. That is why we give steroid. How much steroid we have to give? 24 milligram. 24 milligram in 48 hours. That is how we have to give. There are two options. B, betamethasone, and D, dexamethasone. Betamethasone is the second letter of the alphabet, so it will be given in 2 dosage, as you can see, 2 dosage. And dexamethasone is the fourth, D is the fourth alphabet, so it will be given in 4 dosage. This is exactly what is written in my notes. I have not made any single change to this screenshot. So B given in 2 doses. In how much time? 48 hours. That means 12 milligram each dose at a gap of 24 hours. Betamethasone, and dexamethasone 4 doses, so gap of 12 hours and 6 milligram each dose. 6 into 4, 24 milligram, and 12 into 4, 48 hours. Now why betamethasone is the preferred option? Because it is less plasma protein bound. Betamethasone as compared to dexona is less bound to plasma protein, so it has more transfer across placenta. That is why it can be given in 2 dosage. So now with this you can select the best option. You can select the best option. Betamethasone in 2 doses, so this option is wrong, and dexamethasone in 4 doses, so this option is wrong. So this you can easily rule out. Betamethasone dose is 12 milligrams, so this seems correct, and dexamethasone each dose is 6 milligrams, so this also seems correct. Betamethasone 12 hours apart, that is a very minor but very important point that you have to remember. Betamethasone is given 24 hours apart, so that is why this option is also wrong. That is why this option is wrong. And option number A, dexamethasone 1 dose of 6 milligram, 4 such doses given at an interval of 12 hours. That is the best answer here. That is the best answer here. So I hope you will be able to remember how to solve such question just by looking at this point in our notes. Betamethasone B 2 dosage, dexamethasone with D 4 dosage. How much total dose? 24 milligram. So 2 dosage each will be 12 milligram and 4 dosage each will be 6 milligram. In how much time we have to give? 48 hours. So in betamethasone, there will be a gap of 24 hours between the 2 dosage, and in dexamethasone, since there are 4 doses, so there will be a gap of 12 hours. So if you have studied from my notes, you will be able to solve this question without any problem, even in all upcoming examinations. Okay, so I hope it is clear, and I am giving you the live proof of what is present in our notes, so you can go and check the Manipal MedAce app, and you will believe that actually what we are teaching is what is being asked in the INICET, and obviously INICET is more difficult than NEET, so you can rest assured that all questions in NEET will also come from the notes and lectures. Okay, so I hope that is clear. Moving to the next question. Inhaled nitric oxide. Inhaled nitric oxide. Inhaled nitric oxide is used in pulmonary artery hypertension in neonates. It is used as a reserve drug in neonates who suffer from the pulmonary artery hypertension. Again, this topic, very detailed discussion in my lectures, present in my notes. Pulmonary artery hypertension, when pulmonary artery pressure goes above 22, that is where we define. If vasodilator test, what is vasodilator? Decrease in pulmonary artery pressure on inhaled NO. So you can see inhaled NO mention we have done here. If vasodilator test is positive, drug of choice are calcium channel blockers like amlodipine. And if vasodilator test is negative, there is no fall in pulmonary artery pressure on inhaling NO, then we have to look at the stage. If the patient is at stage 1, 2 and 3, then endothelin antagonist, drugs like bosentan with another oral drug, either sildenafil or riociguat. Riociguat can be used. And if the patient is at a stage 4, the last stage of pulmonary artery hypertension with vasodilator test negative, then you have to look for the inhaled or injectable prostacyclins like treprostinil, epoprostenol. Okay, PGI2 prostacyclin analogs we have to use. And as I told you, neonates, these are treatment for adults. In neonates, inhaled NO, inhaled nitric oxide can also be used. You find mentioned there as well. You find the mention there as well. So pulmonary artery hypertension, very, very important topic, discussed in detail and asked in our exam. This was also emphasized, this topic, in the YouTube session that I took on Manipal MedAce before INICET in April, and we discussed some very important topics. So this is one of the most important topic even for upcoming exam. So I hope so far things are clear. And you are understanding, and you are also realizing that all the questions have come from our notes. In case you find that there is any mistake in the question or any correction, please do let me know. And your thumbs up and your likes have decreased, so please continue to like this session. Next question: which of the following or amongst the following is a HER1 inhibitor? HER1. What is HER1? HER1 is another name for epidermal growth factor receptor. HER1 actually stands for human epidermal growth factor receptor. So HER1 is another name of epidermal growth factor receptor. Epidermal growth factor receptor is also known as HER1. Remember, a slight modification occurs and then the receptor becomes HER2. So HER2 is a different receptor. HER1 is synonymous with epidermal growth factor receptor. So which of the following is a HER1 inhibitor? We look at our notes. We find that from the anti-cancer drugs, targeted therapy, we have discussed epidermal growth factor receptor. What we have discussed, that mutations in this receptor, if mutations occur in EGFR, then patient is at high risk of developing 4 cancer: colorectal cancer, non-small cell lung cancer, head and neck cancer, and pancreatic cancer. These 4 cancers can arise if the patient has a mutation in which receptor? EGFR. Now, which drugs will block this receptor? So this is EGF receptor. It's an enzyme linked receptor. You can see an extracellular part of the receptor and an intracellular part. Intracellular part is a tyrosine kinase, clearly shown, EGF receptor. Which antibodies? This blue antibody you can see, cetuximab, panitumumab. These are 2 important antibodies, cetuximab and panitumumab, and there is also nesi. This is the latest one, nesitumumab. So this is also going to block EGF receptor. So all these 3 drugs, cetuximab, panitumumab and nesitumumab, they are blocking which receptor? EGF receptor or HER1 receptor. Cetuximab is used along with panitumumab in CRC, which is colorectal cancer, and cetuximab is also used for head and neck cancer. Panitumumab does not find much benefit in head and neck cancer, clearly written. Nesitumumab is again drug mainly for colorectal cancer. Now, which other drugs can also inhibit EGF receptor but not antibody? By inhibiting the tyrosine kinase, gefitinib, erlotinib, osimertinib. These drugs are also targeting EGF receptor or HER1, but they are inhibiting the tyrosine kinase intracellular activity of this receptor, again clearly shown in the diagram. This is again a screenshot from my notes. Gefitinib, erlotinib are used in non-small cell cancer. Osimertinib is also used in non-small cell cancer. Now, if you will recall the importance of this topic, then in INICET last year, 2023, they asked in the previous INICET about osimertinib, that patients with non-small cell lung cancer with T790M mutation, this question was asked in last INICET. So this topic is an important topic. Osimertinib, we have discussed NSCLC with T-threonine at 790 position replaced by methionine. If this mutation is present, osimertinib is to be used. This was asked in previous. So that means this was an important topic. Coming back to the question, there is a problem in the question. Which of the following is HER1 inhibitor? So as I told you, necitumumab, cetuximab and panitumumab. All the three drugs A, C and D, A, C and D are against HER1. So I hope the question should have been within except. The question actually should have been except. Maybe because of recall or during recall, this was not correctly framed. But all three A, B, A, C and D are against HER1 or EGFR. Trastuzumab is against the HER2 receptor. HER2. So trastuzumab and pertuzumab, these are two important drugs that target HER2 receptor, and all of you know they are used in cancer of breast. HER2 positive cancer of breast. Trastuzumab, pertuzumab. So I believe the question had an except, and therefore trastuzumab is a drug which does not target HER1, it targets HER2. That is how the question should have been asked. Next, very important, from the important chapter of epilepsy. This question is, or this chapter is always asked. At least one question come from the anti-epileptic drugs every year. Now they have asked cannabidiol. Cannabidiol or cannabinoids is used for treatment of seizure in all of the following except. Now again, cannabidiol is a new drug. It has been asked only once previously. So this was, I would say, a relatively tough question. Again, if you see the options, Lennox-Gastaut, tuberous sclerosis, Dravet syndrome, Rett syndrome, the options are also rare epileptic disorder. But again, when everybody fails, MedAce is there to help you. So you see this. This is again a screenshot from the notes. Dravet syndrome, I have explained in my notes. Dravet syndrome. Which is the drug of choice? Valproate. Valproate is the drug of choice with or without benzodiazepines, clobazam. That is the drug of choice for severe myoclonic epilepsy of infancy or the Dravet syndrome. Which are the add-on drugs? You find which name? Cannabidiol. Cannabidiol is mentioned in my notes as an add-on drugs for Dravet's. So you know cannabidiol is used in Dravet syndrome. You can rule out that option. Further, from the notes only, Lennox-Gastaut syndrome. Lennox-Gastaut syndrome. What is Lennox-Gastaut? There is a child with multiple types of seizure. There is low IQ or mental retardation present, and EEG shows slow wave EEG less than 2.5 Hz. These are the 3 points in diagnosing Lennox-Gastaut. What is the drug of choice? Valproate. Then some other drugs like rufinamide, topiramate, clobazam. But what is written at number 4? We find cannabidiol. So cannabidiol is used in Lennox-Gastaut. Could have been answered from my notes. Cannabidiol, what is cannabidiol? It is a product, oral drug coming out of cannabis plant, tetrahydrocannabinol. But it does not cause euphoria. That is the difference between cannabidiol and other cannabis product. Used as anti-seizure, Lennox-Gastaut, Dravet. Two options you could rule out. So we know it is used in this. So this will not be the answer. Dravets. Rett syndrome you could have answered. Because there is only one new drug that was asked last time. Trofinetide. Trofinetide is a new drug, neuropeptide analog, the IGF-1 analog that has been recently approved for treatment of Rett syndrome, that was asked in last year's INICET. So you know that cannabidiol is unlikely to be used for Rett syndrome. So that is the answer. Dravet's and Lennox-Gastaut is mentioned in my notes, and tuberous sclerosis complex also can be benefited by cannabidiol. So this is how you can answer this particular question. From where this question has been taken, I will show you the exact place from where this question has been taken. So this is a table from the Bible of Pharmacology, which is Goodman and Gilman. You can see seizure type, conventional drug, and recently developed treatment. Okay, what you find here: syndrome specific uses, seizure arising from Dravet's, Lennox-Gastaut, and tuberous sclerosis complex. Syndromes: Dravet syndrome, Lennox-Gastaut, tuberous. Seizures arising from these three conditions can be treated by which drug? Cannabidiol. From this table of Goodman and Gilman, this question has been taken. So the answer is cannabidiol, and this is the reference, the most authentic reference that you can find. Clearly it is written: Dravet syndrome, Lennox-Gastaut, and tuberous sclerosis complex. The seizures arising from these conditions can be treated by cannabidiol. Okay, so this is the answer to this particular question. Another very simple question: match the drug in column A with its site of action in column B. And what drugs we have? Acetazolamide, furosemide, thiazide. That means we have diuretics. Diuretics, once you read from our notes, diuretics you will never ever forget. You can see first diuretic, ACE inhibitor. ACE inhibitor, carbonic anhydrase inhibitor like acetazolamide, where they are acting? PCT. So acetazolamide will act in PCT, clearly shown. Osmotic diuretics like mannitol. What is the main site of action? Descending limb. Ascending limb is the main site, followed by PCT. Main site is descending limb. Loop diuretics like furosemide, clearly shown. What is the main site? Thick ascending limb. Thiazides, hydrochlorothiazide, thiazide, all thiazides act where? DCT, clearly shown, DCT. Okay. Potassium sparing diuretics like amiloride, where they are acting? Late part of DCT or early part of collecting duct. Early part of collecting duct. So all important diuretics have been shown with the diagram, with the name, with the site of action. And if you read from this diagram, from my lectures, you would not have any problem in this. So acetazolamide is a carbonic anhydrase inhibitor. Where it will act? It will act on PCT. So one will go with A. Furosemide, loop diuretic, everybody knows, it will go with C. And thiazide is a moderately sealing diuretic acting in the DCT. So that option number B is the correct answer. Option number B is the correct answer. So this was a simple question. I believe everybody would have solved this. But those who still have any confusion, here we are to help you solve all such questions. Another question which is asked: Veptans, which are called aquauritic. Where do they act? They act, as you can see, in late part of collecting ducts. This is also asked previously. Veptans, which are called aquauritic, they are blocking the vasopressin or the V2 receptor, where? In late part of collecting ducts. This question also has been asked. So from this diagram, even veptans can be understood. Question number 14. So far I have shown you with documented proof, with screenshot, that all questions have come from the notes, from the rapid revision. Moving ahead, cyanide poisoning treatment. Such a simple question, asked so many times, covered in notes, covered in rapid revision, even covered in the reels that we post on the Manipal MedAce Instagram channel. So cyanide poisoning, you see cyanide poisoning in chapter on nitrates in drugs for angina, clearly written. Cyanide poisoning, what are the important situations when it occurs? Inhalation of fire fumes, particularly when plastic burns, then cyanide atoms are created. If you inhale that fume, plastic fire, cyanide poisoning can occur. Sodium nitroprusside contains cyanide atoms, so overdose of sodium nitroprusside can lead to cyanide poisoning. These are two important situations where patient develops cyanide poisoning. Understood? What is the drug of choice? Hydroxycobalamin. You inject hydroxycobalamin, it binds cyanide atom, cyanocobalamin excreted. That is the drug of choice. What is the alternative? You combine a nitrite with sodium thiosulfate. So you give first nitrite and then sodium thiosulfate. They will form thiocyanate, which will be eliminated. So clearly cyanide poisoning, the causes, drug of choice and alternative treatment clearly mentioned. This is all you need to know in cyanide poisoning. and that what has been asked. So whether it is nitrate, ideally it should have been nitrate, nitrite, but even nitrate will be. So these two are useful, and sodium thiosulfate. So answer will be all of these. All of these can be used in treatment of cyanide poisoning. Cyanide poisoning. Okay. So you can see nitrate plus sodium thiosulfate. But what is the drug of choice? Hydroxycobalamin, because that acts fast. Okay. So that is the question number 14, cyanide poisoning. I hope everybody is clear so far, and I'm giving you not just an strike rate which you cannot go back and check. I'm showing you live screenshots from our notes, which are proof in itself to show you that all questions have come from our app. Patients with cough with tenacious sputum. So we have a productive cough. We have what? A productive cough. Best management. 4 options are given. But before going to the options, let's see what we have in our notes. This is for the drugs for cough. Drugs for cough. So you find antitussives. Antitussives are used for non-productive cough, and you have expectorants which are used for productive cough. So this question is about productive cough. So that is where we have to focus. For expectorants, we have 2 kind of drugs that increase pulmonary secretions like sodium citrate, potassium iodide, guanfacine. These drugs are rarely used nowadays. What are used nowadays for productive cough? Mucolytics, which liquefy thick sputum. What is the word given in the option, in the question? Thick, tenacious sputum. That is the same word we have used in our notes. Liquefaction of thick sputum so that it is easy to come out. Mucolytics are the drugs. What are mucolytics? ABC, ambroxol, acetylcysteine, bromhexine, and carbocysteine. So any of these will be the best drug for this particular patient. It is obviously clear. Productive cough, ABC, mucolytics, everything is written. Antitussives like codeine and dextromethorphan, they are used for non-productive cough. Non-productive cough. Clearly, this is all. This is the only thing I have taught in the drugs for cough. Hardly in 5 minutes, and question has come. So cough with the tenacious thick sputum, best management. We are looking for any mucolytics, bromhexine, dextromethorphan, cough suppressant, dry cough. Wrong. Codeine, antitussive, dry cough. Dextromethorphan, dry cough. Bromhexine is the answer. Bromhexine is the answer. Moving ahead, fast acting drug which reverses the action of rocuronium. This is direct question from our anesthesia. Rocuronium, vecuronium. These drugs, the action can be reversed. The action can be reversed even by a neostigmine. But a very fast acting without producing the cholinergic side effect is Sugama-dex. This question I put in our MCQ, covered in anesthesia also. Sugama-dex, it terminates action of rocuronium, vecuronium. First line. What is this Sugama-dex? It is a selective relaxant binding agent. It forms an inactive chelate with rocuronium and vecuronium, and it does not produce the cholinergic side effect with neostigmine. So what you need to understand, for reversing the effect of the skeletal muscle relaxant like rocuronium, vecuronium, you can use neostigmine, but neostigmine will act slowly, and secondly it will produce cholinergic side effects like bradycardia. So we have a selective drug called Sugama-dex, which forms an inactive chelate with rocuronium and vecuronium and can reverse the effect of these drugs. Again, a direct question from our app. Last question, and this is the confusing question. Despite best of my efforts, I could not find the correct option, and I hope this is a controversial question. False about voriconazole. So what we know about voriconazole, that this is used to treat aspergillosis, invasive aspergillosis, where it is drug of choice. This is what we know, that this is true. This is a true statement. Other options are confusing and may not be studied. We cannot study the pharmacokinetic of each and every drug. I hope you all will agree. So whether it is taken empty stomach, given with pyrazamide, need therapeutic drug monitoring, loading dose. So let us see. So this question has been taken line by line from Goodman and Gilman. I'll show you what is written. Voriconazole, fatty meals reduce the bioavailability. So drug should be given either 1 hour before or 1 hour after. So drug should be taken ideally empty stomach. Okay, 1 hour before or 1 hour after meals. You start the dosing IV 6 milligram per kg every 12 years. So there is a loading dose. First to dose you give 6 milligram per kg, then you give 3 milligram per kg, and then oral maintenance dose. So it is given by loading followed by maintenance. So that also is clear. Then therapeutic drug monitoring is frequently used, particularly in children, and the levels that we need is between 1 to 5. These three statements are clearly written in Goodman and Gilman, and drug of choice for invasive aspergillosis. So you come back to the question, it is taken empty stomach, correct. Need therapeutic drug monitoring, true. Loading dose is given, true. Drug for invasive aspergillosis, true. So the false statement could be B. Why this question is given, or this option with pyrazamide? It does not make any sense. Voriconazole is an hepatotoxic drug and pyrazamide is also hepatotoxic. So the combination ideally should not be given, but as such there is no contraindication also. But given with pyrazamide does not make any sense. So I believe this is the only false statement out of these various options that I could find. Okay, so these were the questions that were asked from pharmacology. As I've told you with screenshots, all questions have come from the app, from the notes as such. So Aniket is saying, sir, I'm a second prof student and watch your lectures. Thank you, Aniket. I can't study from KDT because of the language, so I purchased this what will suffice for second prof and PG. So Aniket, I would say with authority here that you watch my lectures completely and you study from my notes from the Manipal MedAce. There is no need for you to read any book, any other notes. First you complete my lectures, my notes, and then you can take up any book, whether it is KDT, whether it is Padmaja, whether it is this Katzung. You will find every book as a piece of cake. You will be able to read through anything. But if you read the notes, if you follow the lectures, you actually do not need anything for prof or for PG. That is a belief. That is something I can say with complete assurance. Okay. So these were the all questions which were asked from pharmacology, and I hope you will find this session very informative and interesting, and I hope you will download the Manipal MedAce app if you have already not done, and also recommend to your friends. So till next time, thank you all, and continue to learn and subscribe to Manipal MedAce. This is Dr. Arpit, your pharmacology guru.